Good morning, members of parliament, support staff, radio listeners, TV viewers, those following via social media, and the members of the media. Welcome to this meeting of the Committee of Public Health, Social Development and Labor, number 6 of today, Thursday, June 16th, 2022. A special welcome to the representatives of the St. Maarten AIDS Foundation and the accompanying guests, Mrs. Connor, Mrs. Isaac, Mrs. Bell, and Mr. Van Osk. We have established a quorum of nine members. Please stand for a moment of silence. Thank you. I received a notice of absence from the following members: MP William Marlin, MP Akim Arendel, MP Christophe Emmanuel, and MP Rolando Bryson. Are there any notifications at this time? I see no need. We have as agenda point for this meeting the presentation on the financial and public health implications as it relates to HIV/AIDS on Dutch Sint Maarten. Before we go over to our agenda point, I would like to adjourn for 5 minutes. Meeting adjourned. Welcome back to this Committee of Public Health, Social Development and Labor meeting of number 6 of today, Thursday, June 16th. We are just adjourned for 5 minutes, and I would like to now go over to the agenda point. On May 31st, 2022, Parliament received a letter from Dr. Gerard van Osk, President of the Sint Maarten AIDS Foundation, with a request for a meeting with the members of Parliament to discuss the above-mentioned agenda point. This document is registered as incoming document IS 964, 2021-2022, dated May 31st, 2022. All members of Parliament received a copy of this letter via email, which can also be found on a P drive of Parliament. At this time, I would like to give the floor to Dr. van Osk for some introductory remarks and a presentation. Dr. van Osk, you have the floor.
Thank you very much, Mr. Chairman, and apologies again for the late start due to the slides that I sent yesterday, but one way or the other didn't arrive yet. Thanks also very much for the invitation, the positive response to our request to talk about what's going on with HIV, what is moving forward, and how we think government should start being more involved. First, I would like to ask some questions, with your permission, Mr. Chairman, to the parliamentarians, to this committee, in the sense that what does government, what does Parliament know about what's going on with HIV, and how government, the island, is involved with HIV prevention and especially care and treatment. And for us to know the mandate of this committee, second question, is what is the mandate of the committee? So how could we move forward with the information we are sharing today?
Thank you, Dr. van Osk. In principle, the Committee of Public Health, the Committee of VSR, we have the mandate to research any topic that relates to that very broad topic, and in this case, it would be health. So what we would then normally do is we would have a meeting with you, and then based off of the meeting, we would see if it would be necessary for us to maybe call in government to have a discussion on the meeting, or maybe send a report to them. And see how we would move forward depending on what the meeting is about. But in theory, that's what the committee does. We research any and all topics that we find it would be relevant to the topic. And in this case, I believe that's the case.
All right, thank you very much, Mr. Chairman. Despite the fact that we as AIDS Foundation have promoted the new developments in HIV/AIDS for many years, we think many people in our community and also representatives of government in the different departments are still kind of stuck in an outdated mindset of fear, ignorance, high prices for treatment, and complicated care for people living with HIV. And things have moved forward so much that I think it's important that everybody gets on the same page to move forward. Prevention for many is still abstinence, staying in a monogamous relationship where both partners are tested, and condom use, difficult to achieve with behavior change modifications, but necessary still to promote because they do work. But prevention and care and treatment have moved on far, and it's time to change the mindset towards HIV. And mind you, I'm calling it HIV and not HIV and AIDS, because AIDS is, yes, the latter stage of an HIV infection, but you contract HIV. You do not contract AIDS. It's the result of it. HIV and the consequences of untreated HIV/AIDS is still seen as, for most, as a scary, deadly disease. While HIV has changed into a manageable condition where with proper care and treatment, people live really the same lifespan as people not infected with HIV, and those not infected, and even where current pricing on Sint Maarten makes it affordable. I compared pricing for somebody who has high blood pressure and diabetes, And basically the price for treatment of such a person is the same as for HIV. And we have no problem covering high blood pressure and diabetes, but many people still think it's difficult to cover HIV. I'll come back to the cost a little later. Modern prevention and care and treatment modalities include treatment as prevention, and that is better known as USU, undetectable equals untransmittable, and pre-exposure prophylaxis. I'm convinced that because I started treatment already for HIV in 1992 on the island, compared to other nations in the Caribbean who started about 10, 15 years later, Sint Maarten, both the Dutch and French side, because French side started treating around the same time, was able to keep the growth of the HIV epidemic on our island under control, despite the high risks because of transient migrant populations, condoned commercial sex work, a large group of gay men and men on the down low, referred to as men having sex with men, and Sint Maarten being known as a sex-liberal island, where tourists and guests shop for more than jewelry and other tax-free items. Stigma at this moment is the killer of HIV, not HIV. And we need to work to reduce stigma. The foundation has been trying to do that for many years, but I think we can't do it alone anymore, and we need assistance with that. I would like to give Ms. Isaac the floor to talk a bit more what stigma in the field of HIV leads to. Thank you very much.
Thank you, Dr. Van Os. I would hereby like to give the floor to Mrs. Isaac for her presentation. Ms. Isaac, you have the floor.
Good morning. Thank you, Mr. Chairman. I would like to present on a slide called Stumping Out Stigma, which is a program that was created by 2 doctors in the U.S. Dr. Vanash, can you forward? Continue. Keep going. Keep going. Keep going. Keep going. Keep going. So we're going to start with this first slide, right? We want to spot stigma, what stigma is, the effects of it, and what it does to people living with HIV, and also the communities that they live in, and also the people that serve them, i.e. providers, public health service, access to health care. So stigma, or the fear of stigma, stops people living with HIV in key populations from the following. Like I just mentioned, accessing health services, getting tested for HIV and STI, accessing treatments, which is their antiretroviral treatments, getting information on how to avoid transmission, getting condoms, lubricants, etc. Openly discussing their sexuality with health workers, providing complete information about their sexual practices, protecting their health and the health of their sexual partners, for example, by insisting on condom use with partners, using clean needles and syringes for drug use, and accessing treatment to reduce viral load. Disclosing their HIV status and getting counseling and care support. Because of stigma, people living with HIV and other key population are often afraid to tell others about their HIV status or even getting tested, especially if they're immigrants in a country or a state and they refuse to come forward, so that causes them to die from complications. Next slide, Dr. Vanash. I will assume everyone knows what stigma is. Stigma is a powerful, discrediting social label that radically changes how an individual is viewed by others and can alter how he or she sees him and herself. Next slide. Next slide. Next slide. Keep going. So there's 2 forms of stigma. There's felt stigma, which refers to how someone may anticipate discrimination and shameful feel associated with it. There's enacted stigma, which is the actual experience of discrimination. Next slide. The way how stigma occurs is it reacts to who you are, meaning your identity, what you have done, your behavior, Sometimes that may not be accurate or current, which is perception. Next slide. Ooh. Stigma, right there. Stigma is a process there's 4 different processes. The point out or label differences, meaning he is different from us or he coughs a lot, i.e. in the case of COVID, there was a lot of stigma. If you were next to someone and they coughed, you assume that they had COVID, so you did not want to be next to them. Attributes differences to negative behavior. His sickness is caused by his sin or promiscuous behavior. Separation, like us versus them, shunning, isolation, rejection, loss of status, and discrimination, meaning loss of respect within your community. Next slide. The 4 levels of stigma are intrapersonal, internalized thoughts, interpersonal, relationship to others, including clients, providers, etc. Institutional, which is the ability to access care, public health services, community and culture, environment that shape prevailing ways of thinking. Next slide. The effects, forms, and causes of stigma are the following. The effects of stigma are shame, denial, self-isolation, loneliness, neglect, loss of hope, depression, death, alcoholism, isolation, self-rejection, giving up on oneself, self-pity, self-blame, withdraw from public activities, becoming very quiet, committing suicide or thoughts of suicide, starting to think about dying alone without loved ones, feeling unprotected, useless, not contributing to society, kicked out or shunned by their family members. Next slide. The forms of stigma are name-calling, scapegoating, finger-pointing, teasing, ridiculing, labeling, suspecting or neglecting that you think that someone has something, so you're stigmatizing them because of that. Next slide. The cause of stigma equals morality, a view that people living with HIV are sinners, promiscuous, unfaithful, sleeping around. People's belief about population contagion and impurity equals fear. Fear of infection, fear of the unknown, fear of death equal ignorance. Lack of knowledge and misconception makes people fear physical contact with people living with HIV. The inferiority and superiority complex, gender and poverty, women and poor people are more stigmatized than men, rich people equals prejudice and tendency to judge others. These are just some of the ways how someone living with HIV are stigmatized. Dr. Vanash.
Thanks very much, Tamisha.
Thank you, Ms. Isaac. For the presentation, I would hereby like to give the word to Dr. Van Os.
Sorry for that. Recently, the AIDS Foundation, together with 2 students from the VU, the Vrije Universiteit in Amsterdam, performed data collection on stigma within our community and amongst people living with HIV on Sint Maarten. We interviewed 36 people living with HIV on the Dutch side, from the English-speaking community, the Spanish-speaking community, and the Haitian Creole-speaking community. We interviewed more than 60 people from the general public as well, and the 2 students are currently working on their master thesis for their studies of public health to finalize the data analysis. But first glance of that research already shows that there is almost 100%, but extremely high internalized stigma amongst people living with HIV on our island because they are fearful for anticipated stigma, namely how will the community respond. And within the interviews we performed with people from the community, it shows that there's really a mix. There's people who now understand there's treatment, so we can move on. Even if you have HIV, you can live with it. And that's why we talk about people living with HIV and not any other way. And there are also still a lot of people who are fearful and stigmatizing because they think, indeed, it's a sin, it's the way you live, so that's the consequence of it, etc. I've asked 600 or more patients I've treated over the years about how they think about this and how they contracted their HIV infection. And all of them, without exception, obviously stated they did not look for it, they didn't ask for it. It was either not being informed or living in a relationship where they did not have a voice, women more than men, and they could not refuse sex or demand condom use, trusting their partners. But stigma is really on Sint Maarten the major killer in HIV, still, because most people, fortunately, who are diagnosed are having access to treatment. And every once in a while, every year actually, and I am aware of that, some people may still be dying, but that is because they're afraid to get into treatment, or they're afraid for their families' responses to the community, employers' responses, etc. So stigma is unfortunately alive, and I think we need to all work to understand that living with HIV is definitely possible, and it's a manageable condition that does not give any risk to anybody else. And I would like to give the floor to Mrs. Connor, who will also introduce a bit who she is and who Tamisha Isaac are, before she explains more about you as you. Undetectable means untransmittable, and PrEP.
Thank you, Dr. Van Os. I would hereby like to give the floor to Mrs. Connor. Mrs. Connor, you have the floor.
Thank you so much. My name is D. Connor, Davina Connor. I am a woman who has lived with HIV for 25 years, as well as Tamisha Isaac for 20 years. I am an advocate, an international speaker, and I am the Creative Engagement Outreach Specialist for Prevention Access Campaign. First, I would like to say that HIV is a public health emergency. Worldwide, it's a public health emergency. No one knows who's living with HIV just by someone sitting next to them. We both, Tamisha and I, have lived and thrived living with HIV, have had children who are HIV negative, and we're living great, beautiful, healthy lives. So the organization that I work for, they started a campaign or a message called U equals U. Undetectable equals untransmittable. This message is widely known worldwide. We have 1,052 partners in 105 countries worldwide. The message of U equals U, the scientists didn't know that the information wasn't getting to the people. See, I can do this verbatim. But you can show here, this slide here. The next one? Yes, you can keep pushing it. So it means a person who lives with HIV, who is on treatment and has an undetectable viral load, virally suppressed. Their viral load is under 200 copies, which it means 199 copies. They have zero transmission of transmitting HIV to their partners. There's actually zero risk, and that is because of the science. We can just listen a couple of minutes, maybe about 60 seconds, to Dr. Fauci at one of the HIV conferences talk about U equals U being the foundation of ending the epidemic of HIV.
I just press.
It doesn't work.
It's not gonna play.
It's okay, but this is what Dr. Fauci says, and he also states that pre-exposure prophylaxis and U equals U. You can't talk about one without talking about the other when it comes to prevention. So PrEP is a prevention measure for people who live with HIV, who are HIV negative, and U equals U is a prevention measure for people who are living with HIV. And you put those two together and you use them when you're speaking about HIV to let people know the prevention side, and that's gonna help lessen and end the transmissions of HIV worldwide. Next slide. So how do we know U equals U? Because of the studies that were done. There were 4 studies done: HPTN-052, Opposites Attract, Partner 1 study, Partner 2 study. And out of all these studies, there were 125,000 condomless sex acts, and there were still 0 transmissions of HIV with the partner who lives with HIV being virally suppressed and undetectable. Next slide. So common science questions. So do people stay undetectable? Of course they do, because adherence. As long as a person who lives with HIV stays in care, stays in treatment, and gets their labs done, they do stay undetectable. A person actually becomes undetectable within 30 days of taking treatment. And the next slide. So this slide here is just to give you a little bit of background really quick. The CDC said in 2017 that there was effectively no risk of a person transmitting HIV who was on treatment, but in 2019, they came back and said there is 0 transmission from a person preventing HIV to their sexual partner, because effectively no risk was actually confusing people. Next slide. And so our U equals U guidelines are TLC. You can keep clicking. So treatment, labs, and care. A person who lives with HIV, we need treatment, labs, and care to actually save our lives, to keep us healthy. Next slide. So again, it's under 200 copies, which is $199 and below. U equals U is about sex. It's about sex and people being liberated and being comfortable with who they are, and knowing that they can be in healthy relationships as long as they stay in care and take care of their health. But we say you may want to use a condom for other STIs and pregnancies. Next slide. So common science questions. STIs were presented within the partner study, but there were still no transmissions of HIV during these studies. So they have no impact on HIV transmission at all when the partner is actually undetectable. Next slide. So ViiV Healthcare did a study, and this study showed that when a provider talks to a person who lives with HIV, you can just keep clicking along. When a provider talks to a person who is living with HIV about being undetectable and virally suppressed, it actually changed their overall health, their mental health, their sexual health. They wanted to stay in care. They wanted to stay virally suppressed. It changed. U equals U has changed everything. It's actually changing the way HIV is looked at. It's changing the stigma within society. People are wanting to get tested now because it's taking away that fear of living with HIV if they do find out that they're living with HIV. And it's also lifting the weight off of a person who is living with HIV with that internalized stigma that they have lived with for so long. Next slide. So prioritizing people who live with HIV first. We must invest in the health of people who live with HIV first if we want to get to ending the transmissions of HIV. So treatment and care to stay healthy comes first. We also have to stop the new transmissions, and again, to prioritize people who live with HIV. To increase access and treatment, commit to using the U equals U rally cries. We always tell everybody to use this. If we don't use our voices to help our community, especially the communities who are disproportionately affected by HIV, we can't get to the root of the problem. I say back in the 80s, they found a solution to the problem. We all have to find a solution to this problem so we can end this epidemic in our communities. Next slide. And that's it. Thank you. Thank you, Chair. They're not going to play. Yeah.
Thank you, Ms. Connor, for that presentation. I would like to give the floor back to Dr. Van Os. Dr. Van Os, you have the floor.
Thank you very much, Mr. Chairman. So with this updated knowledge, I think we do have to look differently to HIV from what most of us have done, especially in the view of care and treatment and even prevention. We have to look also in how government has, or as the AIDS Foundation thinks, has not been involved in care and treatment for HIV on Sint Maarten. We were the first, or one of the first countries in the Caribbean starting HIV treatment in 1992, but we're currently the last country in the Caribbean where government does not have a sustainable plan how to proceed with HIV care and treatment for the future, especially with me leaving the island and me basically having done all the care and treatment, or most of it, on the Dutch side. Offering care and treatment to people living with HIV, like Tamisha said, is not an ethical problem anymore. It's really a public health problem. If you do not treat everyone, and I mean everyone who's living with HIV in your community, you don't only let morbidity, illness rise, but you also continue to allow transmission of HIV in your community. In 2001, the then ruling government on Sint Maarten approved an HIV/AIDS strategic plan for Sint Maarten. However, without a budget to hire a manager to lead the project. The AIDS Foundation, through seed money of the AIDS funds in Holland, received 3 years' worth of salary for Ms. Suzette Moses, who was the program manager. After a while, we received subsidy from government to basically pay her salary because there was no salary allotted by government for her position. So it was kind of vestzak, broekzak, but bottom line, for many years, the NGO was actually first fully through Dutch funding, subsidizing government, and later on with subsidy from government. Finally, government took over the salary payment. The HIV program management team, led by Ms. Suzette Moses, worked from 2002 till 2014. In 2014, a next strategic plan was developed, but it was never implemented. That strategic plan contained the first initiative for government to become more involved with care and treatment, but like I said, it was never implemented. In 2013, the EU funded developing a policy for Sint Maarten. It was channeled, the money, through PAHO, to develop an HIV/AIDS care standard for Sint Maarten. So that's a document from 2013. We have a few copies available for the interested members, and we can send it by email to you as well, because it's a lot of pages. Now, that document obviously may not be up to date anymore, but instead of reinventing the wheel again, I think it's important that we look at that document and see how we could quickly move forward. That document never was implemented, and it's still in a drawer. Recently, Department CPS, we had a meeting with them about our subsidy for overhead for the AIDS Foundation. They were not aware of that document, so we made contact with the person, Axion, who developed it together with me, and we provided them also with a copy of the document. So unfortunately, we think that government has not really made a plan how to make HIV care and treatment sustainable on Sint Maarten. About 12 years ago, Dr. Edward Green, the United Nations Secretary General, Special Envoy for HIV in the Caribbean, already told Sint Maarten that having HIV care and treatment rest in the hands of one private physician, in casu myself, without government having a plan, was a time bomb waiting to click, because if I would fall away for whatever reason, and that is going to happen in the next few months, care and treatment will possibly be an issue. Let's go back to the cost for HIV. I've prepared a document, and I didn't want to share it before, but we'll share it now. I'll just use this slide as a summary of that document, because what I did, I looked at the current pricing for HIV, for the medications, for consultations, for lab work for people living with HIV, and I calculated what the lifetime cost is for an individual being diagnosed around 25, where most of people are diagnosed on our island, living a normal lifespan of any human being. For a male, that is currently 79 years, but women live longer. And people living with HIV can live that normal lifespan once they have proper care and treatment. That lifelong cost would add up, HIV treatment alone, to 464,000 guilders. Let's say rounded off to 500,000. But we need to keep in mind that that is with current pricing. Mrs. Tamara Landino, the pharmacist of Simpson Bay Pharmacy, and myself have done a heck of a lot of work to get the price down. For the same medicine we're treating now, Biktarvy, we used to pay close to $1,000, and now we're paying $200. So it's gotten much cheaper. We were actually blocked by the Inspectorate of Public Health for 3 years, introducing 1 pill a day medications because the pharmaceutical industry, Gilead, was not willing to register it yet on Sint Maarten. They were willing to register, but with a small community like ours, they didn't want to spend the legal and financial resources to do the registration work on Sint Maarten, and that is why it was not possible to buy it for this cheap price, $200. So the inspectorate indicated buy it in Holland, where it was around €1,000 per bottle. And we said, Essedway won't be able to finance that. And eventually, Mrs. Landino and myself found a legal backdoor in the system where we can still import Biktarvy and use it for our patients. And before I retired in October 2020, I made sure that all my patients who were not on single drug medications yet were now on 1 pill a day, the cheaper medication, so that reduced cost. Obviously, people living with HIV also has a chance to develop diabetes, high blood pressure, cancer, and other conditions, so that will increase the price of care and treatment. I also looked at what it costs per year to treat an individual, a person living with HIV. And if we talk about first-line treatment, and that is what you see there, that is the 1 pill a day. Once people start on treatment, they're not resistant to any medications. They can take 1 tablet a day. That would end up being about $4,100 per year per person, which is about, let's say, 7,500 guilders per person. If we look at second line, when people did not use their medication for whatever reason well enough, they become resistant to the medicine. You use second line treatment, as we call it, and that is a little bit more expensive. Over the past many years, I started treating uninsured people living with HIV in 1990. And so all these years I've been treating uninsured people living with HIV. It started off with 3 or 4, then it became 7 and 9, and now over the past years we budgeted with our funding requests to different organizations for 20 people, because after the hurricane and then with COVID we were anticipating more people losing their job and needing assistance. And in reality we had 20 people under our care, 22 people under our care at one point, but on average it's 13 to 17 people living with HIV uninsured that I take care of. And that would end up being about 100,000 to 130,000 guilders a year. So government very often, when I'm in meetings with the health department and CPS and public health, think that it is extremely expensive and they won't be able to afford it. Obviously, I have no view of the budget of the government, but I would think with that investment you would per year, you would be able to treat everybody on Sint Maarten, and that way we could really come not only to a situation where people living with HIV, all of them are healthy, but also transmission to the community, because if you don't treat uninsured people, and that is going to finish, mind you, February next year, We have funding from R4CR. We've looked for funding all the time. Till 2017, I was constantly collecting medication from people who were switching their medication, who were passing away. I was getting donations from the French side sometimes from patients who switched. I was getting donations from the United States where I had friends. I was going to Holland on my vacations and going to hospitals to collect medications. And that's how I was able till 2017 without any financial involvement from the foundation to treat everybody. But then since it's 1 pill a day and everybody's staying on 1 pill a day, people don't switch anymore, basically. So I could not find medications anymore. Donations dried up as well. And now we're purchasing medications with funding from organizations like R4CR, the Dutch Red Cross, the Dutch Recovery Fund after Hurricane Irma, Samenwerkende Fonds in Holland. And currently we have a 1-year subsidy for care and treatment until February 2023 from R4CR. They have already indicated that they will not continue. I'm leaving the island in October, so I will continue care and treatment through Zoom, WhatsApp, email, etc. What I'm doing now already, because basically I'm still treating my HIV patients because nobody really took over. So government will have to decide, of course, if this is affordable enough to offer HIV treatment to everyone, including the ones uninsured. And mind you, the uninsured are not all undocumented. 65 to 70% of people living with HIV that are uninsured, that we care for, are residents on Sint Maarten. They have either a temporary or a permanent residency on Sint Maarten, but for administrative complicated reasons, sometimes OZR cards are taking time to renew. SZV coverage is sometimes taking time to renew, and in the meantime, the couple of months they are out of their insurance, we assist them. Another thing that I think government should look into. For more than 15 years, I collected surveillance data free of charge from the French side, SLS lab, and my colleagues and my own patients. To get a better picture of the incidence, the new transmissions of HIV on a yearly basis, and prevalence of HIV on our island, how many people living with HIV on our island. These were always checked by Dr. Izzy Gerstenbloed, the epidemiologist of the Netherlands Antilles at the time, and still basically functioning as such for our island as well, to some extent at times. In addition, I collaborated with the French side to use their surveillance system, and I entered all the data of all my patients from 1989 to October 2020 into that database. So we had, that was the only disease on Sint Maarten basically we had data on. I discussed many times with government, with PAHO representatives they introduced, to see how we could use those data, continue to use and enter data to have proper planning tools, but government never took a decision on which program they wanted to use. I made contact with the Dutch AIDS Monitoring Foundation, who were willing to take over that data collection and all the analysis that it needs, but government was looking at PAHO programs and never took a decision. All the data, basically 30 years of data on HIV, demographics, resistance data, what are people using, etc., got lost when I retired in October 2020. And I told government that this was going to happen, but again, no response. So where are we at the moment? HIV care is not covered when you're doing that as a GP, as a general practitioner. I've been working 32 years as a general practitioner on the island, and we receive a subscription fee. SZV considers us as a GP. There's no extra financing for HIV, which is specialized work. You need to keep updated, study, and it's longer than usual consultations most of the time. And because it's not covered, and you get basically, at the time when I was working, $83 a year for 15 consultations, which usually take longer than usual and are specialized consultations. So none of my colleagues was ever willing to take over or be involved because it's too time-consuming and they didn't want to get involved. Then, when I retired, at that time, 220 people living with HIV I was caring for still fortunately stayed by Dr. Simmons, who is renting the office that Dr. Herles and I have in our possession. And he took over all my patients, HIV patients, knowing that he would not get paid for the work he would be doing. I gave him and his staff some introductory course on HIV care, but the bottom line is that all the questions and problems are still coming to me by WhatsApp, email, and telephone conversations, and sometimes I go into the clinic there to counsel patients. He usually refers if there's a problem that he doesn't know, and other colleagues also refer to Dr. Naderi in the hospital, the infectious disease specialist, who, as you may know, is every month a couple of weeks off island to visit his family, and that means that his waiting time to see him is 2.5 months. I checked with the hospital, and that means that if you're newly diagnosed, mind you, imagine you're newly diagnosed with HIV and you don't receive counseling and information and care and treatment for at least 2.5 months until that starts, and then new lab tests, more money, and then eventually you may end up into treatment. As at SMMC, the hospital is not able to do anything for uninsured people living with HIV. If somebody is admitted with HIV and is uninsured, they will handle it if it's really necessary in the hospital still, but then once the patient is released, the patient ends up with a big bill. I've had patients uninsured come to me with bills of 6,000 or 10,000 guilders, which they will never be able to pay, so hospital will have to, one way or the other, absorb that. But the uninsured patient then comes under my care again, and as I said, in February next year, that funding will dry up. It's not new to government that I'm leaving the island. I've mentioned this for more than 5 years, that this is what's going to happen. I actually stayed longer than planned, and the time has come, so it's crunch time, that we come up with some form of solution to make care and treatment for people living with HIV, all of the people, not only the insured, but also the uninsured, sustainable for the future, knowing that you is you. I think, just to give a short example, like I said before, 65 to 70% is actually resident, temporary, or permanent on the island. The very few that are really undocumented, and it's very few in that group over the past 4 years, 4.5 years since Irma, are situations like a lady of 62 has been living on Sint Maarten for 21 years. Her Haitian husband passed away from HIV/AIDS complications. He found that his wife needed to be home to care for him, which she did all those years. He didn't take his medication properly, passed away. She's now 62, has been living here 21 years, and is undocumented still, because he never wanted to take care of her paperwork. Through the assistance of a lawyer, she's able to now obtain a temporary immigration permit. However, to be able to get that in your hand, you need a medical insurance. She can't get a private insurance because she has a pre-existing condition. Under the current OZR regulations, you have to be at least permanent resident or Dutch citizen to obtain that. SZV, if you're 62 and you don't have much of an education, then it's cleaning in a private household maybe, but you won't be able to obtain SZV coverage. She was actually able illegally to obtain SZV because, as you know, many people kind of pay employers to get them on the list, but SZV, understandably and rightfully so, noticed that that is an illegal practice, so she lost that when she was indeed, through a friend, on a loan list, an income list. Another case, a boy infected from baby by his HIV-infected mother, a Haitian lady. I know him since he is 3 years old. His mother passed away in Haiti. There was initially no death certificate, so his dad could not, who lives on Sint Maarten, is permanent resident on Sint Maarten, he could have gotten his child under SZV. There was no death certificate, so we had to take care of finding a death certificate in Haiti. Eventually, he was able to adopt under his name this child, but unfortunately, the father doesn't do anything for his child. And for all these years, he's now close to 20. I've been treating him because he was undocumented on Sint Maarten. He did not have a passport. And I tried through the lieutenant governor, through the judge, through the court of guardianship to get him in some kind of documentation. He's born on Sint Maarten, has never been in Haiti. He's now finally, because we helped him financially to get his passport, he's now working on getting immigration papers, immigration documentation. And then he's now finishing his education. And hopefully soon will work so he can obtain SZV. Now, these are situations that I've been running into over and over the years, and I've always tried to solve problems, and if I couldn't solve them, at least treated these persons. And for instance, this young guy, obviously when he became a teenager, he becomes interested in sex. And I had to make very much sure that he was having an undetectable HIV viral load, because otherwise, as a young teenager trying to fit in, he may be transmitting his HIV to others, whereas this is totally preventable. So those are just some examples. And my question to the committee is definitely, because I've been talking for more than 15 years with the ministers of public health, with the ministry, public health, the SGs, CPS, et cetera, and I'm now at a point where I say this is my last opportunity to make known that you is you. Treatment for all is, I think, a requirement. It's 100% public health issue, and I think it's time that we together look at this situation, and don't just look at Dr. Van Osch or at the AIDS Foundation who need to solve this problem. We need to do that together. Thank you very much, Mr. Chairman.
Thank you, Dr. Van Osch, for your presentation, and ladies as well. It was a very extensive presentation. A lot of information was shared. I look now to the floor and see if I can give any member of parliament the floor. I see MP Gomes. Raise your hand, MP Gomes, you have the floor.
Thank you, Mr. Chairman, and good afternoon to my colleagues, to you, to Fifir, and to the Dr. Van Osch and your support today. Thank you for the very clear, eye-opening presentation. I think those of us who've been following the AIDS Foundation know most of this, that your work in the community as well as Ms. Moses' work over the years. I wanted to ask, what is the prevalency rate for the island? I heard you mention 200 patients that you handed over to Dr. Simmons upon your retirement, which again, I also knew about, so I assume government knew about it. So if we could just get that information from me, Mr. Chairman, I think that, as you mentioned earlier, this committee now has the possibility to bring in the minister and ask some questions of him and also of SZV regarding the treatment for these patients. And I think the work that the AIDS Foundation has done in educating people on prevention of HIV transmission, and now I think anyone who's followed it along the years knows about as well. Undetectable is untransmittable, and I think that that should be the next step then of this committee to get these answers. We've asked the Minister of Education before as well about sex education and whether there are progressive programs happening in the schools, because I think that is also the root part of starting prevention. But we all know what answer we got for that. So looking forward to the answer to the question. Thank you.
Thank you, MP Gomes, for your question. I would hereby like to give the floor to MP Duncan for some remarks. MP Duncan, you have the floor.
Thank you, Mr. Chairman. Good morning to you. Good morning to my colleagues here in Parliament, the SG. Good morning to Dr. Van Osh. Good morning to Mrs. Bell. And a good morning to the ladies. Thank you so much for the presentation. I also want to just say thank you, Dr. Van Osh, for all the work that you have done. As a child growing up, I remember my first AIDS-related death and seeing you in the neighborhood and knowing that you have put in decades worth of work. I would just like to say thank you, and to the AIDS Foundation as well. What we have on Sint Maarten is an issue where our foundations do so much work, and government, I guess, kind of says, hey, you know, well, if you're doing the work and maybe the problem is not as extreme as it can be, we can sit back and relax a little bit. And the time has come now that that is no longer sustainable and something needs to be done. And so for me, I also want to know, because so much information has been provided and this committee has a responsibility to ask government and to call the minister in to ask them first what is happening with the strategy, at least the last strategy that was presented. So I will definitely support a call for a meeting to ask government what is happening. But also to, through you, Mr. Chairman, to Dr. Van Osh, what would you say is your biggest fear when you leave Sint Maarten? Thank you, Mr. Chairman.
Thank you, MP Duncan, for your questions. I would hereby like to give the floor to MP Westcott Williams for some remarks. MP, you have the floor.
Thank you, Mr. Chairman, and good afternoon. A good afternoon to my colleagues. A good afternoon to Dr. Van Osh, to Mrs. Bell, to Mrs. Connor, Otalor, and Mrs. Isaac. Thank you for the presentation and the information provided. Let me start out by echoing the sentiments of my colleague who spoke before me, and that is expressing thanks to all of you to start with, and in particular Dr. Van Osh. And I say this because, Dr. Van Osh, you and I have worked many years together on this project and on this program. You mentioned the EU program, and you would recall that at a certain time, I, back then, carried the responsibility for that regional program, HIV/AIDS program. And the amount of work and effort that you put in, along with some very dedicated PAHO officials at the time, it was really amazing. And I have heard your plea for so many years, so many years. I recall you at a point saying, basically in order to get reaction and action, saying, and I guess you did it on more than one occasion, that was the end for you at the time. And you still continued year after year after year. So really having sort of been there and just a tip of what you were involved in, I can but say thank you for the service that you have given to the community of Sint Maarten. During those years, I too learned so much that unless you really immerse yourself into it, you just would not know. And numbers really started to mean something. So that's my first thing. Question, Dr. Van Osh, you mentioned that the information that you have gathered and collected and from different sources, that is was lost when you retired. Could you explain that a little more, please? When you say that is lost. And tying into that question, in again looking to see what information do we have as a country regarding HIV/AIDS, and I came up against, I think it was in a PAHOS paper, information back in 2013, 2014, and two questions pertaining to that. Is there more recent information such as that? One, and what would you say that has, from the numbers that I remember, the prevalence was growing until maybe 2011, somewhere around there, and then it kind of stabilized. So my question directly to you is, what contributed to that? Is it what you just explained in terms of the treatment, however you were able to do it, and you did it? So if you can maybe go into that a little for me, and then sort of piggybacking on another question. So right now it is clear what you are saying to this committee, that you believe, in your view, is necessary, definitely a plan, because we can decide, put some money in a budget next year, and then but a year after, there are you. What are the other steps? So that type of a accepted plan is important. And you mentioned the issue of awareness. Now looking at the stigma part of it, continuing with that type of awareness. Is there any other matter going forward that you would say to this committee in asking questions and doing what the committee can do? Is there anything else that you would like to pass along in terms of how we move forward? Thank you, Mr. Chairman, for the opportunity.
Thank you, MP Westcott Williams, for your questions and remarks. I would hereby like to give the floor to MP Bijlani for your remarks. MP Bijlani, you have the floor.
Thank you, Chairman. Good afternoon to you. Good afternoon to the Griffier. Good afternoon to my colleagues, and good afternoon to the team here. Very touching and in-depth what you all discussed here. And I would also like to join my colleague MPs in knowing Dr. Van Hosh, how much he has did into this. And I'm missing Mr. Rajesh Chintaman also. I know the person, whenever I see him, I know he has something up his sleeves to help with the HIV and AIDS. What I would like to know is, if you have any data that how many from past years that you've been working, how many have got into HIV, and on yearly basis, how many people have we lost in Sint Maarten due to AIDS? And one more question would be to the ladies here who gave their own personal presentation. Is I know the list of things that you can do with being a HIV. I would like to know the list of things that you cannot do being into this, if it's possible. Thank you, Chairman.
Thank you, MP Bijlani, for your questions. I would hereby like to give the floor to MP Pontiflet. MP, you have the floor.
Thank you, Mr. Chairman. Good afternoon to the Chair, my colleagues in Parliament, Griffier, of course, Dr. Van Hoff, Mrs. Bell, Mrs. Connor, Mrs. Isaac, for, as one of my colleagues before me said, open, transparent information regards to personal experience, because I think that's very important. My first experience with someone who was HIV positive was some 30 years or more ago. And I can remember very well we were walking through the parking lot, and when they saw me, they were going to turn away. And I walked to them and I hugged them. Because at least I was aware you can't get it by hugging, you know, because back then it was something new, so people were very, very afraid and skeptical. But I realized very quickly that person like that felt isolated and so on, as if, you know, they have some kind of a disease that can be passed on, a transmittable disease that can be passed on by just physical touch, which I realized was not the case, and I decided to hug that person. Of course, unfortunately, it was no longer than 6 or 7 months after they passed, because again, it was something new, and it was not, they didn't really have all necessary medication in order to deal with it at that time. So I want to thank you for being open, and thank you, Dr. Fanosh, again, for the very in-depth information. I don't want to say surprised, but I believe that in this present age, I would think that basically even with television and so on, that people will be more aware as to what the possibilities are, and that definitely you can live a very productive, enjoyable life with it. I was happy to hear that it has gone to one pill now, because back in the day I used to see persons with a bunch of tablets and so on. I said, wow, you know, it's like a whole pharmacy you're traveling with. But thank God today, you know, it has gone down to just one pill. Mr. Chairman, to you, Dr. Fanosh mentioned a care standard, a report from 2013. I just want to find it, can it be used still? Because I think you mentioned do not reinvent the wheel. You can look at it and see exactly what can be adjusted in order to ensure that we use that. I think it's important that, and some of my colleagues said it, that definitely government should be called in to find exactly what it is that they should do, because I don't say can, but should, because you have said it for years and years, sounding the alarm years and years and so on. The cause would be more not to deal with it. So I think it's important that definitely we deal with it at this present stage, because it can have other effects like employment, stress in the family, so many other things can happen because it was not dealt with at this stage. So I think it's important that we call in the government and ensure that we get this matter addressed as soon as possible, and it be a consistent effort placed in the budget, whatever. Yes, it is money, but at the same time, someone said, pay now better than later. Thank you, Mr. Chairman.
Thank you. Ample time to flood for those remarks. I hereby look to the speakers list, and I see that MP Rumu is next. MP, you have the floor.
Thank you, Mr. Chairman. A pleasant good morning to you, pleasant good morning to my colleagues, and of course, a pleasant good morning to Dr. Vanosh, Mrs. Bell, Ms. Connor, and Mrs. Isaac. I want to thank you as well for quite an extensive presentation. I am sure for many here, and also those viewing and listening, some of the information given was unknown, and quite an eye-opener for many, because as Dr. Vanosh stated, HIV/AIDS Foundation has been in St. Maarten for a very long time and has been doing a tremendous job. Dr. Vanosh, you almost brought tears to my eyes when you said you're leaving, because sometimes, and I know this for a fact, that persons who are driven and have a passion for what they're doing, most of the times you can't find a replacement. So I do hope that you have been training someone, or that someone that is as passionate as you are when it comes to this, that can take over the mantle. And what I want to ask is two questions. In your presentation, you talked about the strategic plan, and you said that the first one, I believe, was done in 2001, and then I heard you mention another year, I think 2015. My question is, and I know that you have definitely been following up with government, do you know what were the bottlenecks, especially before 10-10-10, because I know after 10-10-10, we've had a lot of instability, so I can understand a lot of things not moving forward because of the constant change of governments. But we didn't quite have that before 10-10-10. So what, in your estimation, or what were you told was the bottleneck in terms of not having that strategic plan being implemented? And also, I know that there are quite a number of programs within the school when it comes to awareness. Are you also in the schools giving awareness when it comes to the HIV/AIDS? Because I know of Girl Power, I know of Real Talk. I'm not quite sure about the HIV/AIDS. And is it something that is given, from primary school as well as secondary school? Or is it just secondary school that you are in there? Because as one of my colleagues said, I believe that when it comes to providing information and knowledge, we must start from the cradle, and it's very important. I know some people might see it as a big topic, but I'm sure they can find ways to educate the younger ones on this as well. Thank you, Mr. Chairman.
Thank you, MP Rumu, for those remarks. I hereby look to the speakers list and see if there are any other MPs that wish to have the floor. MP De Weaver, you have the floor.
Thank you, Mr. Chairman. I was contemplating whether or not I would go, but I think it's important to share my sentiments and my reaction to your presentation. Thank you, first off. Good morning, good afternoon now to everyone. Thank you, good afternoon to you. Thank you all for being here. And walking, as you were all presenting, initially the feelings that I have was one of complete astonishment and shock and concern. And then it moved into extreme anger. And then it moved into sadness, because you have been doing this for how long? How long have you put this in front of government to deal with it? And 30 years you have been treating people. I kept writing notes down when you were there. And when I say you, I mean you and your support team. And that's why I went through those transitions of feeling different things. And I'm actually really happy that we don't have a wide angle shot of us here while you were talking, because then people could actually see my reactions, because I'm not so good at having a poker face. And I really have to say thank you for educating me. Thank you for bringing this to my attention. And I will take a step out and say that we are safe on this island because of the work that you've done. We have been able to live a carefree life because of the work that you've done. And we should now all be concerned that this is not being taken care of, or there's no transition period. And I want to really re-emphasize the fact that we are safe because you kept this under control with your team. And that's the alternative we have, is that if we don't have a person or a group of persons to transfer this to, then all of that safety and comfort and carefree living that we have enjoyed will no longer exist. It's not to fearmonger, it's because people need to understand that this has been kept under wraps. People have been educated because of your effort. And even though I have not been involved in the AIDS Foundation and volunteering with it, I was also unaware of the urgency of this. And I'm so glad that we had a very brief communication before this meeting was called. And the shock already started from then, that I even was speaking to some of my colleagues in here before we started this meeting. So everyone has asked the questions that I considered asking as well, but I really hope that everyone that is tuning into this live, whether they're looking at it online or listening on the radio, and that will tune into it later on, understands that this is something that is urgent. Everyone has shown you gratitude, and there's nothing else that we can tell you right now for gratitude. And now I feel the focus should be on the urgency of making sure that we have everything in place to continue the program that you started back in 1989 when you started practicing, and 1992 when you started treating. With that said, I would like a copy of the 2013 report. And then you mentioned the funding. You said the portion of the funding was coming from the Dutch government. And when I'm talking about the funding, I mean the funding related only to the treatment, not the funding related to the policy with PAHO supporting the policy. The treatment that has happened over the years, I think you said 2002 to 2014, just to get an understanding of the split of financing for it. So between Dutch government, there was a subsidy done by Sint Maarten. So it's not to offend any previous governments that nothing was ever done. What I can say is nothing was ever done in making sure that we had a continuity plan in place. That's the reality of it. So there's no pussyfooting here and, walking on eggshells. Let's just be real and call it what it is. That is just for me to get an idea of the total cost associated with it, how it was split in the past, how it can be carried over in the future. In addition to that, I think that's everything. Thank you very much.
Thank you, Amby de Weaver, for your kind remarks and questions. I just want to make it clear that we did receive the 2013 document in the email. It was sent to all members of Parliament, so we should have that one. And also the last document that Dr. Van Os referred to regarding the certain calculations, that one has also been sent to the members of Parliament for our perusal. I look to the floor and see if there are any other comments. I see MP Heilige Maarten. MP Heilige Maarten, you have the floor.
Thank you, Mr. Chairman. Is it working? Yes. I'll be extremely brief, seeing that I'm the last MP on the list and everyone spoke. I would like to wish you a good afternoon, first and foremost, Dr. Van Osch, Mrs. Bell Martin, Mrs. Connor Otler, and Mrs. Isaac. Otler, did I say it correctly? Oh, Thaler. Have me apologized. I would like to unanimously, echo the sentiments of all my members of Parliament, my colleagues here that stated the same thing. Dr. Van Osch, you and I go way back, as one of your patients as well. I would like to congratulate you and thank you from the bottom of our heart on behalf of Parliament, on behalf of Sint Maarten. Thank you for all your hard work and dedication. And based on what we have heard here today, the alarming message that has touched us all here today, know that it does have our attention. Parliament will be going on recess in the next 2 weeks, but note that this will be a priority for us to try and get to the bottom of this, as we know that it is a time-consuming, the clock is ticking. So we will make sure that we will hopefully find a solution. I just have one small, maybe 2 questions just before we close. Is the subsidy. What kind of subsidy should we have in place? What kind of budget should we have in place for this to run optimally on a yearly basis? What is that budget? What is that number that works for you? And secondly, and lastly, the strategic plan 2014. You mentioned many plans. Have you recently updated one and put something in place that we can have, that would succeed you when you leave? Do you have a present plan in place that can work for the next coming 5 years after you leave? And have you met with the Minister of Health recently, Minister Otley, on any of your recent anytime recently, since he's been in his, I think he's been here for 1 year already. So have you ever met with the minister and discussed this with the minister of your plans to leave, and knowing the most importantly that we need something in place for when you leave us in October? I'm saying it without, But with that, Mr. Chairman, that's all I have, and I look forward to the answers by Dr. Van Osch.
Thank you, MP Heilige Maarten. I look back and I see that MP de Weaver has a remark. MP, you have the floor.
Thank you, Mr. Chairman. I towards the end I kind of forgot, but after listening to MP Heilige Maarten speak, it reminded me of why I asked you for the split of in the past, what the subsidy split was or the financing split was. Is because for us to get an idea of the total cost, because we also have budget coming up. So if worst case scenario, this is exactly one of those budget amendments you want to add in. That's what I wanted to put out there and say publicly. Thank you.
Thank you, MP de Weaver. I look to the floor. I don't see any other members who wish to have the floor. I myself would like to have 1 or 2 remarks. I, of course, also want to thank the Foundation for their work. I, too, am privy to some of the work that you guys have done through a personal friend of mine, Ms. Nadia Fleming, who I believe is a project coordinator at the Sint Maarten AIDS Foundation. I just had 2 questions. One of them is also budgetary, of course, but the other one, I was looking to at the first line and the second line treatments, and I see the difference in per year was about $1,400. I was just curious as to what is the difference. I know that when it comes to the first line HIV treatment, we're using Biktarvy, the 1 pill a day, but what is the difference between that treatment and the treatment for somebody in second line who I believe would be, let's say, suppressing the workings of only the pill, so they would need some additional medication. I just wanted to know how that goes. And then, of course, coming back to the budget, I want to echo what MP Py21-22 and MP De Wever said. We do need to look at the money. And as the good MP before me said, we do have budget coming in this week, so this year, within the next couple of months, hopefully. So an amendment, I think, could be in place, given what is to come. But also then we would need some more information as to what the necessities are, as to what is the total amount needed, what is the total amount that you think should be subsidized, because of course we would have to then have a dialogue with government, because of course we would want to say we want money, but we do need to look within the constructs of what we can do. But so basically an indication as to what exactly we would need. So to echo MP Py21-22's her comment. And again, thank you for the presentation, and I look forward to some of the answers. Thank you guys once again. Thank you, members of Parliament, for all your remarks and questions. I now look back to Dr. Van Osh and see to who I can give the floor. If you guys maybe need some time to come up with the answers. Dr. Van Osh, you have the floor.
Thank you, Mr. Chairman. One question to MP De Wever about this breakdown of budget. Are you referring to the development, the EU development money at the time that was channeled because it was basically 11 countries, overseas countries and territories that received money from the EU. It was channeled through the PAHO office of PAHO, the Caribbean PAHO office. Is that what you're referring at?
MP De Wever.
Thank you. When I was listening to the presentation, what I picked up from it was the split of costs. So I know that there was a portion that was financed. So maybe it's just a clarification of what was funded through Dutch funding. There was also a subsidy, I made a note of, with subsidy from government. And then I took a note of, for the years 2002 to 2014. So it was just overall how this has been financed over the years. So not necessarily going back to 2002, 2014. I just saw that it was a combination of financiers, or a combination of where the money was coming from to continue supporting this program. So it was just clarification on that, so that it could help me get a better understanding of what we need to have as the bottom line, or an approximate figure of managing this on an annual basis, or paying for this on an annual basis.
Thank you, MP De Wever. I hereby give the floor back to Dr. Van Osh. Doctor, you have the floor.
Thank you, Mr. Chairman. I would be able, I think, to answer most questions at this point. Not sure if anybody needs to have a little break. I don't know how your meetings normally go, so.
Yeah, I think a 10-minute break should be in order for now for us to catch ourselves. Hereby, we're going to take a 10-minute break. Meeting adjourned. Welcome back, members of Parliament and Smart and AIDS Foundation, and to everybody else tuning in. We just had some remarks and questions from the members of Parliament. I would like to make a note to Dr. Van Osch. The questions that inquire you to maybe do some calculations, those we don't have a problem receiving those answers in writing, because I do know that you have to go and access your documents and stuff, to get the relevant information for us. But I would hereby also like to give the floor to you to answer all the rest of the questions to your best capabilities. Thank you. You have the floor.
Thank you, Mr. Chairman. I'll first start with the questions of MP Gums. She asked something about, let's say, the numbers. In the early years, so there's good news, let's say it this way. In the early years, based on calculations of more the French side, extrapolating numbers of pregnant women with HIV especially, and looking at those numbers, where most of the pregnant women having HIV were actually cared for on the French side in the early years, and the early years meaning early 90s. We then thought there was a prevalence of about 3% of people living with HIV on Sint Maarten. It eventually went down when we recalculated with PAHO, if I'm not mistaken, that it went down to 1.5% of prevalence, and currently I'm looking more at numbers of 1 to 1.5% of people living with HIV on our island. And then we're looking at the entire island together, of course. You cannot look at only the Dutch side with a situation and an issue as HIV. When we look at numbers under care at the moment, as I mentioned, I had 220 people under my care when I retired. I asked the hospital many times through either the infectious disease specialist or the directory of the hospital to give me the numbers of the hospital that are under care there. I never received an answer despite multiple requests, and I assumed, based on what the pharmacy was able to give me at some point as number of medications supplied, of about anywhere between 80 and 100 probably under care in the hospital. The French side, when I inquired last year with them, currently has something like 570, if I'm not mistaken, under their care. Now, if we take the hospital for 80, that would be 870 people, and this is, again, don't pin me on the number, but that gives you an idea of people currently under care on the island, both Dutch and French side together. That means with a prevalence estimated at 1 to 1.5%, and we all know that statistical data of our demographics are always different from who you ask, so we kind of rounded off to 100,000 island-wide. That means 1,000, 1,200 people living with HIV estimated. So that means we're still missing a few hundred, but we're not missing hundreds and hundreds. It's not going to be growing that much, but on the other hand, we also know that there's a constant migration of people to our island and from our island. The good thing of that is that all Caribbean islands currently have care and treatment plans in place, very often organized in a public fashion. In other words, the government takes care of it. In other words, even if we have influx of migrants, chances are they already are under treatment and most likely undetectable and untransmittable. Another good news is that for decades, I can dare to say at the moment, we have not had children infected through their pregnant HIV-infected mother infected anymore. The last child born with HIV was in 2000, and that is a child where the mother was extremely depressed, never came for checkups, and basically only after delivery we found out that she had HIV and her child unfortunately got infected. But the good news is actually all the children born with HIV on island are now teenagers, and a number of them have children of themselves because, again, you is you, and you don't transmit HIV to your partner if you take care, and the mother doesn't transmit it to the child, because the mother will be on treatment and cannot transmit it to her baby. I would like to give the floor to Ms. Judith Bell, our Executive Director, to explain a little bit more about the programs of the AIDS Foundation, including especially the youth programs you were referring at, what's happening in the schools.
Thank you, Dr. Van Orth. I would hereby like to give the floor to Ms. Bell for her remarks. Ms. Bell, you have the floor.
Thank you, Mr. Chairman. Good afternoon, members of Parliament. Parliamentarian Ms. Rameau did ask if there were any programs in the schools, and I am happy to say that we are very prevalent in the schools. In first form, we give the Real Talk to the boys and Girl Power program to the girls in all the high schools. However, we do believe, and most high schools, just about all of them, they're all receptive to this. They look forward to having their students take these workshops that we provide. I believe, though, that government really should make it mandatory that these programs are given in all the high schools. We do private schools and as well as the public. In those programs, it's 3 days, 3 hours each day for Girl Power and Real Talk. We depend on volunteers from the community. And that's another thing. We have volunteers that actually work in government departments. And we believe that as a government, they should be doing community service. So this is a great opportunity for their employees to give back to the community. So when you have someone that is a trained facilitator, because we do training for our volunteers, that when they come to you as a department head and ask you for those 3 days, 3 hours each day, that you cooperate and give them the time, because it's not time that they're using for their personal use. They're helping the youth of the island. So I would really like government to do something about that as well. In the programs, Girl Power, Real Talk, we provide information on HIV, how you can acquire HIV, how can you prevent HIV. We go into contraception, we go into STIs, we go into healthy and unhealthy relationships, we go into self-esteem, we go into goals for their future and mapping their goals, and what happens if you maybe acquire an STI, how is that going to affect your goal, and things of that sort. So we have 3 days, 3 hours each day of quite a few topics that are covered. We do pre-questionnaires and post-questionnaires, so we find out how much the student actually knew before the workshop, and then we can find out how has the workshop helped and benefited the student. In fourth form, we've started the Girl Power in 2006. In 2013, we started Real Talk, and in 2018, we now have the Booster program. The Booster program is provided to the fourth form students in the high schools. It's a recap of what they learned when they were in first form, and also, by fourth form, we have found that a lot of our students are sexually active, not all, but a lot, and have questions of their own. And it provides a confidential setting for them to ask these questions that maybe they don't have anyone that they can go to and ask. What's happening? I've been at the St. Maarten AIDS Foundation since 2017, and I have seen the number of grammar schools turning to us and calling us and telling us that, hey, Mrs. Bell, we have some students that are sexually active already in 5th and 6th grade. So we have our puberty and growing up presentation that we provide for elementary students, where we touch on STIs, we touch on HIV, it's a growing up, we talk about the changes in their body going through puberty, we talk about a little touch on contraceptive. We don't delve into it greatly because these are elementary students. So these programs we provide for the students in the schools. We also have our community liaison officer, Alicia Torres, who one of her responsibilities is to go to the brothels and educate the sexual workers and test the sexual workers in the brothels as well. So that is another educational program. We've had several churches now start calling us and going in and asking if we could provide some workshops to their youth in their churches. And so we have gone into that. So we not only do HIV testing, which we offer for free at our office in Coal Bay, and we go out into the communities. In fact, our community liaison person just met with the EDS on the French side, and we will be conducting testing in the communities because they have a nice small bus that can reach the communities easily. Mostly our government bus is too large and it's not even functioning most of the time. So we work along with EDS, the French side, to do testing in the communities. We do have the programs. We also have our Facebook page. We also have our website. We also have Instagram, where the public can get whatever information that they might want. They ask questions, we answer. And so those are just some of the activities that we do at the foundation.
Thank you, Mrs. Bell. I would hereby like to give the word back to Dr. Van Osch. Doctor, you have the floor.
Thank you, Mr. Chairman. Yeah, in addition, I want to mention testing, of course, is important, and making it available and free of charge and confidential, where people don't need to give their names, because the only way that we can treat everybody is if we test as many people as possible, and we work together with the French side there. And concerning the commercial sex workers, I think you're all aware that the policies have changed towards the condonement of brothels and dance clubs through the years. Initially, the women working there had to come in with a negative HIV test and can only stay 3 months, and then eventually it became 6 months and longer. And at that time, some of the physicians that voluntarily did that still tested the commercial sex workers working there, but slowly but surely that kind of fell through. I asked the Public Health Department and CPS, who is now checking if women are actually HIV negative or have any other STIs, and nobody is checking anything, although there is a policy, so-called, a health policy even for commercial sex workers, what they have to comply as sole proprietors, as they, I think, now looked at, but nobody's really checking anything. So the fact that at least we offer HIV testing and we give education and condoms there keeps us a little safer, but I think there can be improvement there. Then there is there's a policy, sexual and reproductive health policy, the SG of Mrs. Joy Arnell made that public a couple of years ago. The foundation was with Mr. Rajesh Gentleman, who was at the time our executive director, involved in the development of that policy, but we offered many times what can we do to help implement steps in that, to implement that policy. And every time, basically, we don't get an answer. So again, there's a policy government has, but to our knowledge, very little is done with that. I think I answered this way all your questions, MP Gums. I'm looking at the chairman. Yeah, all the questions were answered. Then there were the questions, Mr. Chairman, of MP Duncan, who indicated very clearly and I want to repeat that because I think it's important to repeat that sitting back is not sustainable anymore. We can't just look at the AIDS Foundation or Dr. Van Osch or any single individual to look how we're going to solve this for the long term in a sustainable manner. I realize that healthcare, physicians, hospital even in a certain way, and pharmacies are private entities. There's no public healthcare per se on Sint Maarten, although we do have, of course, a public health department. But everything is done through private entities, and that doesn't necessarily make it easy all the time, because now you need to work with people in the field who have to try and implement what government suggests them to do. And then obviously there has to be a budget to entice them to do that, because as I mentioned before, because HIV care by a GP is not covered, the GPs were never willing to involve. And sure, the physician in the hospital is having a salary, but there's no incentive to really do more than necessarily, I think. And I mentioned Dr. Naderi. I spoke to Dr. Van Essen as well and other colleagues in the hospital. And basically when Dr. Naderi is not there, I understand that if they do have a question, they communicate through WhatsApp with Dr. Naderi. So it's not that there's no HIV healthcare at all, but they are not specialists in that field. So it means they can't just quickly take decisions and move forward. They have to communicate with a physician who is not on island some of the time per month. MP Duncan asked me what is my biggest fear when I leave. I'm obviously very concerned, and I think I expressed that sufficiently, that HIV care and treatment will kind of not fall apart, but it will fall to smaller pieces, or it won't come to a halt, because we could of course refer all the patients I used to care for to the hospital, but Dr. Naderi already indicated that in principle he could do that, but him not being there some of the time, it doesn't really make sense to do that, because then people may have to wait long months before they get answers to their health questions and care questions. So that's not necessarily, and he's already extremely busy. So I discussed with the director of the hospital, Dr. Holliday, that when they hire a new internal medicine specialist, that they would have to look into hiring another infectious disease specialist. Not sure how that has developed in the meantime. I know that there's rotating physicians at times, and in how far they are infectious disease specialists, I'm not aware of. So I'm concerned that transmission of HIV, especially having the uninsured, maybe not being able to access care and treatment the way it is organized now, that there will be transmission to the community from them, because, hey, people are human beings, and sex is part of being a human being, so they don't stop having sex. And I look to my lovely ladies to the right, and they're obviously telling that they have children and that they have relationships. That's normal. People living with HIV have any kind of relationship because they're normal people. So that's my biggest concern, I think. I will stay available for a while still through WhatsApp, email, telephone, etc. But you can imagine my life goes on at some point, and that will also come to a halt. I hope I have answered your questions that way, Mr. Chairman and MP Duncan. Then there was the questions of MP Westcott Williams. She asked about the data lost. When I retired in October, 1st of October 2020, we entered all the last data I had on lab tests and information from the patients I was caring for at the time. I asked the NADIS system, which has its server based in Nice in France, because it's a French governmental system that is used everywhere. And the reason that I choose that system is that way I could communicate with my French colleagues on the French side. They know who I have as a patient, and I know them because patients move from over the border, and then they sometimes don't know which medicines they used in the past, or they even say they never had treatment, and then I can look in the system like, actually you did have treatment and you became resistant for these medications, so I cannot give you that medication anymore. And the French side was vice versa, able to do the same thing. Those data basically stopped registering October 2020, so they're now a little bit outdated because I don't know what happened in the meantime. In addition, patients from the hospital, I discussed in the beginning with Dr. Jolles when he was still working, he was not time-wise able to do any data entry. As I mentioned, I offered to have the Dutch organization to government. I offered the Dutch organization, HIV Monitoring Foundation, take over all the data entry. They do that in Curacao. They enter data, they analyze the data, and Curacao, in that way, HIV data-wise, surveillance-wise, is compared, for instance, to Dutch data. What is going on? Where can we improve? As I mentioned, government did not take a decision which system to use, and eventually those contacts were lost again. What information do we have? Do we have recent information? To be honestly true, I don't think so. Till 2014, I was doing this yearly looking at all the surveillance data from the entire island, because I was working together still currently, but at the time working together also with my French counterparts. I was taking the results from SLS, ADC before that, looked at my own patient population, checked with physicians, because testing at the time was done in different steps and people kind of fell out of the registration system. So I checked with all my colleagues every year who had patients that were tested but never got a result, et cetera, et cetera. And that way we got decent prevalence and incidence numbers up until 2014. I decided in 2014 that I would ask government to help me a bit pay for the nurse who did my data entry and my own work, because I did it for free, and never received an answer from government whether they would be willing to assist me with data entry and analysis. Neither did they take a decision on which program to use for the future. So we don't really have data, I think, at the moment, no accurate data. The Department of CPS, if I'm not mistaken, had, let's say, annual infectious disease data up until a couple of years ago. I blew my head off, to be honestly true, in one of the last meetings I had with them about that, because the numbers about STIs that were reported to PAHO through that document were totally ridiculous. I mean, they would indicate that there were 2 cases of chlamydia per year, and then when I asked, where do you get that information from? Well, that's what the lab is telling us. And then if I already see at least 10, 20 people with chlamydia per year in my clinic, then obviously it would have also been possible to call clinics and get ideas what is going on in the clinics, what do people see. But in other words, and even my HIV data, which I had worked hard on to offer to government, were misrepresented. And then at some point I said, you know what, I'm done with this. So I did not update government anymore with those information, but I continued my data entry in Addis up until October 2020, because I wanted to know for myself what is going on, how many new patients and things like that. Incidence has gone down, like you mentioned. Early years it was in the, let's say, 35, Dutch side, 35 new individuals diagnosed with HIV, and that went down to 20 something, 24, and eventually when I stopped it was around 18 or 15 per year. And to be honestly true, I have no idea what the current incidence rate is. I have the feeling, talking to my colleagues, that it's still relatively low. It's not rising, it's not going haywire, but HIV, people are still being infected with HIV. Also, We have, like I said, new influx of people, so numbers are rising. And obviously prevalence, people living with HIV, as we discussed today, stay alive. So the number of people living with HIV on our island will slowly but surely rise, because every year there's some incidence of newly diagnosed persons. We have to look at that. MP Westcott Williams asked me about what kind of plans are necessary. Obviously, I do think we have to look at Stigma. From the Stigma results that we'll get hopefully by mid-July, when the students from the VU in Amsterdam finish their analysis and write their thesis. And we asked them even to come up with some kind of suggested program we could implement. Now, they will have to look at what is done elsewhere, but there's very little done elsewhere. I know that Suzette Moses initially, when she was still working, there was a plan that every governmental, and I don't know the multi-sectoral approach, I think it was called, or something like, every government department had to appoint one person responsible within that department to do something for labor or for women affairs or for youth affairs or for economics or et cetera, et cetera. That was the idea, because if she would stop working, which happened in 2014, at least every department would have something happening. And unfortunately, that never really was happening, because there's other deadlines to meet, and HIV is obviously, for most departments, not a priority. So we need to work on stigma, because if we continue to stigmatize people living with HIV, this will not become what I've said for many, many years, just another medical condition. This is nothing special. People living with HIV are normal people, women, men, gay men, down low men. They're having absolutely normal lives, and with care and treatment, they can live absolutely normal lives. And unfortunately, we couldn't watch the USU videos from some of the people living with HIV talking about it, but they indicate very clearly, it liberated me. I now feel that I can live. I now feel that I'm not infecting anybody else. My first partner on Sint Maarten was a local guy, Elton, as some of you may know, and that was in a time, early 90s, when HIV, we didn't know everything yet, and care and treatment was not even that good yet, because we only had AZT. I actually started treatment with HIV medications because I wanted to keep him alive, and there was no HIV medication. None of the physicians wanted to do anything, including in the hospital. Nobody wanted to touch, almost sometimes, even physicians. So then I started to keep him alive, and that from there it started growing. But we need to look at stigma, how to reduce that. This is a normal, this is one of the medical conditions we have in our society, and we just need to treat it as such. It's manageable, it has become more affordable, and we need to stop looking at this like sinners, dirty people, etc. There is when Suzette Moses was still working, she worked with the secondary schools and the primary schools to develop curricula for sexual health education, healthy choice education. As far as I know, though, I think for the secondary schools it was actually finalized, but it was never implemented. Again, policies, plans written, but not introduced in the school curriculum. And then, of course, USU for all, we really need to make sure that everybody living with HIV on the Dutch side has some way or the other access to treatment. And as a government, you could set certain restrictions even. You need to live so many years on the island before you're entitled, or because, mind you, in that calculation I made, are we only going to cover the public health issue, HIV, or if someone in addition has diabetes, high blood pressure, or cancer, are we going to cover that as well for an uninsured or undocumented person? And then come probably ethical thoughts in mind as well. The French side is doing that, paid by France, but are we able and willing to do the same? Or are we only covering our backsides by covering HIV, so it's not a public health issue transmission-wise. So that's decisions that government need to look into, I think, and need to realize you're opening a little box and new things will pop up. We have to be aware of that. MP Westcott, I hope I answered your questions that way, Mr. Chairman. Then, Mr. Chairman, MP Bislani, he's currently not present, but I still would like to answer his questions. I already mentioned HIV, how many, so things have improved somewhat, but the number of people living with HIV obviously is increasing every year simply because some people get infected. And then he wanted to know how many lost. Now, when I started doing this work in '89, everybody at that time, including my partner, unfortunately passed away. The ones I diagnosed in '92, '94, and lived long enough on not very effective medications, AZT, D4T, and other medications, till '96 when I started combination treatment when it became available. Basically, they're still alive. If they took their medication correctly, some of them became resistant because early days, and Ms. Isaac and Ms. Connor can vie for that. In the beginning, it was like 18, 20 pills a day, very toxic, diarrhea, nausea, vomiting, feeling tired. So the alternative was dying from AIDS or taking the medication, but people were less adherent to their treatments because it was so heavy and so many pills. That has changed now. There's hardly any side effects anymore. So people now starting treatment have a much better outlook, I think, and way of living than at the time. So at that time, everybody was dying in the beginning. Now, hardly anybody. And as far as I know, last year, I don't know the numbers for the hospitals, but from what I've seen, probably only 1 or 2 passed away from HIV, and it was pure stigma. It was not the HIV, it was stigma that killed them. And this year there are rumors, everybody is aware of that. Unfortunately, we're still in the Middle Ages sometimes. I think we're not moving forward with this. Whether it's true, the story or not, I don't even know. And I don't really care, because we need to look at the stigma that is surrounding that, and that is what is caused in the community again. And the pain that is caused to the people who are part of this story. But maybe that was another person due to stigma who passed away because the person was not able to tell family or friends and move forward. MP Bislani also asked, what can you not do?
1 second, Dr. Van Oud. I would just like to give you a little notice that we do have another meeting for 2 o'clock. No mean to rush you, but we do have another meeting for 2 o'clock, so if you could just
rushing me a little bit. So.
A little bit. No, my apologies for that, but I do also see the persons for the next meeting also receiving. So you can continue, Dr. Van Oud.
Yeah. I would like to give the word to Ms. Isaac for that.
Thank you so much, Dr. Van Oud. Ms. Isaac, you have the floor.
Thank you, Mr. Chairman. Thank you, Dr. Van Osh. So I would like to answer MP Bijlani's answer when he asked, what can a person living with HIV do or not do? Just to give you guys a quick little backstory. I was diagnosed with HIV when I was 19 years old. I fled. I'm originally from Sint Maarten, the French side. I actually left my home due to that DV and ended up in New York with my father's side of the family. A year later, I was diagnosed with HIV. I was an undocumented woman in New York City with an HIV diagnosis, and of course, I felt like my life was lost. However, the way how the public health system in New York works is it doesn't matter whether you're documented, undocumented, you will receive assistance because of HIV is a public health crisis. So my answer to MP Bijlani is, here I am now, almost 40 years, have 2 beautiful children who are HIV negative. I am undetectable, been undetectable for a very long time. So my answer to that is, someone living with HIV and thriving with HIV can live a normal, healthy life as long as they take care of themselves, they take their antiretroviral therapy the way they're supposed to, they adhere to it, they communicate with their provider, and they could live just like any normal person. Thank you.
Thank you, Mrs. Isaac. I would like to give the floor back to Dr. Van Os. Doctor, you have the floor.
Thank you, Mr. Chairman, and thank you, Tamisha, for sharing that. Questions of MP Pantoflet. Indeed, we can hug, live together, kiss, eat together, party together, and even have sex together, even without a condom, as long as we make sure that everybody's receiving the access to care, affordable for everybody, even if they're undocumented or waiting for their insurance. We need to fill the gaps, you could say. MP Pantoflet asked, like, why is it with all this information out there that people are still unaware? I think we have to realize, and I've done HIV work in Haiti as well in the early 90s, when you try to live your life on Sint Maarten as well, which is considered a mid-income country internationally wise, many people live from paycheck to paycheck, and then your interest is more to how do I pay the school fees, how do I get food on the plate, how do I keep everybody clean, et cetera, et cetera, et cetera. So obviously, call it ignorance, call it their attention understandably being at other places to keep things running in the family. Many are living in single-parent families, another situation. So yeah, what is it? Is it ignorance? Because the information is out there. If I would have to constantly survive, then I probably wouldn't be interested in buying a condom myself. Or some, I mean, they're for free by us, so they can come for free, but my thought process is different. Can the report of 2013 still be used? I didn't go in detail, but I know enough of that report because I was part writing it. It mentions that we need to train 2 or 3 physicians that are capable and willing to do HIV care. We need to make sure that they get paid for the extra work they do. There was even, by the same Action organization, requested by government, a new tariff system developed where indeed chronic care like diabetes, cancer, hypertension, including HIV, would be able, people who provide that kind of care would, healthcare workers could get some extra money for that. So you entice physicians to actually be part of it. HIV first-line treatment is now, as far as I'm concerned, so simple compared to what it was many years ago that I actually think that every GP should be able to do this. I mean, as long as we treat or train people. Another thing was there that we would have a case manager. It had another name, but a nurse trained to give counseling, to make sure that people are in treatment and remain in treatment. So we looked at different ways how to really make sure that things would run smoothly. So I think a lot of this is still usable, but we need to look at what it will cost with current prices to actually implement it. I think I answered your questions as well. The questions of MP Roumou, Mr. Chairman. No, nobody is trained as yet. Dr. Naderi is very knowledgeable, but to my knowledge, the only one in the hospital at the moment with sufficient knowledge about the current modern care and treatment. And as I mentioned, understandably so, he goes off island on a monthly basis, and when I spoke to him a while ago, he was actually planning to go on a sabbatical for a while, so I don't know how that is moving forward. There was another question from MP Rumu about the strategic plans. The first one was 2001. They were usually plans for 5 years. So with funding, I think more like government funding when the HIV/AIDS program management team was working, and the second strategic plan was developed, and then the second strategic plan was evaluated with money from the EU Development Fund channeled through PAHO, and a new strategic plan was written. But when Suzette left, or actually government decided to close down the HIV/AIDS management team, that strategic plan was never implemented. So it's in a drawer somewhere, if at all. I don't know. The bottlenecks before 10-10-10. I think it's time, and all MPs have supported that thought that it's time to take decisions. Over the past decades, government did not take any decisions in care and treatment for HIV. It was just left like, oh, doc looks like he's taking care. Nobody really dying. I didn't hear anything. So, and even when I stopped working and told government, hey, I'm going to stop, so you'll need to really crunch time, find a solution, things are still going on because Doc Vanosh is still basically answering all the questions for free. And that cannot continue. So care and treatment decisions about uninsured, how we move forward, and how do we get surveillance data to do proper planning. Those are, I think, for now, the bottlenecks. Then I think I answered your questions, MP Rumo, then MP De Wever. Yeah, obviously I've been concerned. Now I can say I've been pissed once in a while, because you can imagine the frustration if every time you spend time to meet with people, with ministers, with departments, and basically nothing is changing. You feel not alone, because we got people around, and I've had a nice team of volunteers around. I'm definitely not alone, but things need to improve. There isn't urgency to it, and then you wanted to know how were the funding, the money for the program management team. They had a budget to implement, a small budget to implement things. Initially, Suzette worked alone, paid by us, but she worked full-time for government. That lasted 3 years, and eventually she got team members in her program management team, and those shifted at times. Those were paid by government salaries. Initially, the subsidy that was on the budget from government, I at the time was almost alone doing HIV prevention and care and treatment work. So I said to government, well, I'm very happy you put a budget for the AIDS Foundation on the budget, but I don't have volunteers and people to do anything. So keep the budget. And then eventually Suzette and I spoke with Lieutenant Governor Richards at the time to ask, could we get the subsidy that is already approved for the AIDS Foundation to pay for the salary of Suzette. So it's something that was on the budget already approved, not a salary for Suzette, but a subsidy for the AIDS Foundation. So that's how we paid her again, until eventually, for about the last 2 or 3 years of her tenure, government actually finally took over. And mind you, and I'll say this publicly again, when she started working for government, paid by the AIDS Foundation, I had discussed, unfortunately didn't get it in writing, that government would take care of the medical insurance of her. And then when Puntje bij Paaltje came, and she actually got sick, because we know her situation as well, and she was almost dying in my hands, I had no other choice than to give her an insurance, because government in Parliament, or in the council, the island council at the time, decided they could not give her a government insurance, although we knew that certain consultants were receiving government support at the time. So that's one of those moments I get pissed and I need to find a solution. So I had to lower her salary. Well, you know how that goes. She did get the same amount. I lowered her salary and she was able to get a ZV, because that was for me the only way to keep her alive, move forward, and keep her operational for government. So those were the tricks I had to play in the field to move forward. So there was a little budget for the HIV/AIDS management team, and in 2014, government decided to stop it because there's other important things: diabetes, chronic other diseases. So it's not HIV that is the most, or even the biggest priority. It's one of the priorities. The CUP money, the EU money, all the money that we received from the EU, channeled through the Caribbean Office of PAHO, went into what the HIV/AIDS management team was doing. So it stayed with government. AIDS Foundation did not see a penny of that money. I discussed with Suzette. All the money was properly accounted for. We did a CUP study, a study amongst the youth, which helped us develop Real Talk. CUP is knowledge, attitudes, what is P again, and B is behavior. So that was financed. The evaluation of the strategic plan of government was financed from it. The writing of a new plan was financed with international assistance from PAHO and PANCUP at the time, paid for with money. And Suzette also did the RED campaign, an extremely successful campaign between public-private enterprises to bring awareness amongst the public to the island. I think I answered your questions as well, MP De Wever, Mr. Chairman, and MP Heiliger, the questions. I'm very happy that and thanks again that we were able to have this meeting. I'm very happy that it was public, so it's not just within chambers that we know this now. The public can be aware of it and ask questions as well. Subsidy needed. AIDS Foundation, I can't give you the exact numbers, but the AIDS Foundation over the last few years, because every year we send in a request for subsidy, and we include all the programs we do in that subsidy request. We don't get that amount of money, as you're aware of. So I know that the last two ones were anywhere between 350,000 and 400,000 guilders subsidy, but that includes overhead and all the programs we do. And all the programs, mind you, government is subsidizing our overhead, but this last subsidy we received after God knows how many emails and basically telling government we're going to close down because we didn't have money anymore. Girl Power, Real Talk, Booster, and our youth wing are financed by SMDF, so indirectly part of that is government. Care and Treatment has, over the past 5.5 years, been financed by, after Irma, the Dutch Recovery Fund, Dutch Red Cross, Samenwerkende Fondsen, R4CR. I think those are the ones who financed it. Government did not pay anything into it. The rest we do basically, I mean, AUC, the students in AUC assist us, and AUC themselves assist us with getting money to pay for testing. So that is covered very often by AUC, and most of the things we pay for ourselves. We actually paid for Care and Treatment ourselves from our fundraising budget we did over the years for about a year ourselves without any external assistance. You asked MP Heiliger if there's a plan in place. No, unfortunately not. And I'm not in the position at this moment to say I'm going to write a plan, because we've written plans, and it's now time to look at the plans and say what will we not implement, what will it cost if we put a figure to it. I don't know the salary scales of government workers, etc., or what in a tariff system for general practitioners, it could be more interesting for people to do specialized work, etc., etc.? Do we need a specialist in the hospital? No, those are things we need to look into, but there is no plan at this moment, and like I said, it's crunch time. We were extremely happy when, for World AIDS Day 2021, and I always mess up the name, but Chantal Groeneveld, head of the Department of Human Development and Community and something, a long name. They approached us, and Ms. Groeneveld was the cabinet assistant of Minister Lee, and I had many meetings with Minister Lee about the new medications and about the subsidy and et cetera, et cetera. So she knew that what happened, and after Minister Lee had to stop working, she was moved to another department. So she made contact with me. Can we do something for World AIDS Day? That was the first time since 2014 that government approached us in doing something for HIV, prevention activities, and we had speech competition, which was excellently organized by the department. We had testing, we had Tamisha and Pedro make interviews, 2 interviews, which went online with DACOM and on our website about HIV 101, so the basic information and living with HIV. So that is what we did. I think I answered your questions, MP Heiliger, and then last but not least, MP Peterson. What's the difference between first and second line? First line at the moment is 1 pill a day. We are using Biktarvy. It's basically Biktarvy or Triumac. Now, Biktarvy is produced by Gilead, and Gilead, we actually went, Tamara Landino and I, to Miami to talk to Gilead to give us a better price, because the price was still at about almost $1,000 for a bottle of 30 pills. And due to that, they invited other Caribbean countries, and we came together, and they were willing to give the really poorer, like Haiti countries, even a better price, but the mid-income price for us became around $200 for a bottle of 30 pills, 1 month supply. Second line used to be around at least $1,000 more, because you need to add medications. Now, what we try to do is try to find 3 new medications. Cocktail treatment is now 3 pills, 3 medicines in 1 pill, and it used to be 3 or 4 different pills and many pills per medication, and now it's 3 medications in 1 pill. Now you have Triumac, which is produced by Viv in England. I contacted them, and they were not willing to lower the price. So we choose for Biktarvy to keep it affordable for Sint Maarten. And I've always tried to do that. Keep in mind, HIV medications are expensive. They used to be, and every bottle of medicine that would go lost because they expire or because people change medication would give the pharmacy at the time such a loss in finances, which is not covered by this, at that time, 7 gulden receptregelvergoeding. So it would take about 11 years to recoup the money if 1 bottle would go lost. And I made very sure that nothing got lost in the years to keep it affordable and the pharmacy willing to purchase the medicine. So second line becomes 2 or 3 medications. I'm using 3 medications once a day, 3 pills, because that is cheaper than the alternative 2 pills once a day, because again, the inspectorate did not allow us to import the cheaper versions of that particular medication. So then it becomes 3 pills once a day, at least, with most of our patients. And the absolute majority, I would dare to say 90% of people are on 1 pill a day, so on the cheaper version. And the second line has now gone from 1,000 to about, the last I just paid for one of our patients under care, 341. I put it in the calculation as $350 for a month's supply of 3 different medications, because they have become generic, some of them. We need to look at the budget. Again, I don't know what it costs. I calculated based on the medication price, consultation price, laboratory price, what it would cost. But obviously, sometimes when government gets involved, people see a profit and they will charge more or things. I just spoke to Tamara Landino this morning. Government has approved a new law, so when I state in my calculation $230 for a bottle of Big Tarvi, with the new system it'll go to probably about $210, because the new system is, I think, $10 receptregelvergoeding or 16 guilder or something like that. So it will get a little bit cheaper, because I took actually the mid between SZV and OZR price. And OZR currently is still something like 1.4 or 5 markup or something. So I took the prices I knew at the time. Things will change a bit, but not drastically, and probably even get cheaper in the new system that government has approved for the pharmacies for their remuneration. I think I answered also MP Peterson's questions, and sorry that I went over time.
Okay, thank you again, Dr. Van Os, for all of the remarks and all of the information. It's highly appreciated by the members of Parliament. We do have some time constraints, so I will be closing this meeting soon. I would like to thank the representatives of the Sint Maarten AIDS Foundation and their guests for their presentation and their presence here today, and for providing us with all of these different topics that I think that has informed a lot of us. I would like to make a proposal, and that is to propose a meeting, maybe a committee meeting of the Committee VSA with the Minister of VSA and also with SZV regarding the treatment and the strategy plan for HIV and AIDS on Sint Maarten. And I do also suggest that all documents of this meeting be forwarded to the ministry before we invite them in. So I would like to see if there are any objections to that. I see no objections, so we're good to go. Ladies and gentlemen, we have come to the end of this meeting. Thank you, everybody, for your participation, and I hereby close this meeting.
Thank you. Thank you very much.